A 5-year-old patient, Whitney, presents to the emergency room. A physical exam revealed that she had a rash which presented with pale pink centers. It was noted that her temperature was 38 degrees Celsius or 100 degrees Fahrenheit, and also she complained of joint pain. The mother said her child was otherwise in perfect health except for 2 weeks ago when her child complained of a sore throat. The mother said she gave her some salt and water to gargle, and it resolved after a few days. What is the most likely diagnosis? Okay, so there are some key points in this case that I would love to highlight as they are key findings for the topics that we will be discussing today, which are rheumatic fever and rheumatic heart disease. First things first, let's talk about acute rheumatic fever. This is classified as an immunologically mediated disease, which is secondary to pharyngitis, more commonly known as sore throat, caused by Group A Streptococcus infection. Recall that Group A Streptococcus is both coagulase negative and beta hemolytic. An example of this is Streptococcus pyogenes. Now, let's get back to the meat of the matter. Acute rheumatic fever is the most common acquired cardiac disease in children and young adults aged 5 to 15 years. It's always important to do a throat swab check for strep pyogenes or give prophylactic antibiotics to children ages 5 to 15 years old who present with a sore throat. This reduces the risk of developing acute rheumatic fever. In terms of pathogenesis, typically, acute rheumatic fever will present 2 to 6 weeks after a sore throat infection. This is very important to note because that's how long it takes the body to mount a full response against the bacteria. This response is a hypersensitivity type 2 reaction. You should remember that a type 2 hypersensitivity reaction involves antibodies binding to the surface antigens on the body's cells, which are mistaken for foreign antigens. Therefore, with that said, the body overreacts to an M protein which is present on the cell surface of the bacteria. This then results in anti-M antibodies not only targeting the bacteria but the heart tissue as well, because there are similar M proteins present on the heart. This cross-reactivity is known as molecular mimicry. So remember, this type 2 hypersensitivity reaction takes place over the course of 2 weeks after the initial sore throat infection. Whenever diagnosing a disease, there are certain criteria that must be met. In the case of Whitney, she was perfectly fine a couple days after the sore throat, but now she's presenting to you after 2 weeks. Since we understand the pathogenesis and the first signs to look out for, let's look into how the patient will present to you. The main clinical features that the patient will present with are carditis and arthritis, inflammation of the heart and the joints respectively. However, for the patient to meet the case definition, they need to satisfy the Jones criteria. The criteria for diagnosis is evidence of previous Group A strep infection indicated by a positive throat swab, as I mentioned earlier, or positive serum titer for anti-streptolysin O, anti-streptococcal DNase, and either 2 major manifestations or 1 major and 2 minor manifestations, as we will discuss. The major manifestations include carditis. This usually presents as pericardial friction rubs, heart murmurs, and a high pulse rate. Polyarthritis. This usually occurs in 80% of patients. As the name suggests, pain felt in multiple joints. Sydenham's chorea. This is classified as rapid, uncoordinated, jerky movements. I want you to remember this manifestation even though it appears in only 25% of patients. It will appear in neuroscience too, and I want you to remember that it usually happens due to rheumatic fever. Thus, Sydenham chorea happens in young children, while Huntington chorea happens in adulthood. If you want to be a brilliant student, you can document that Sydenham can be treated with haloperidol. Erythema marginatum. This involves a rash with a pale pink center which spreads to the trunk and limbs. Subcutaneous nodules is also a major criteria. To remember the major criteria, just use the Jones mnemonic. J, joints for polyarthritis. And O, well, O kind of looks like a heart, so pancarditis. N for subcutaneous nodules, and E for erythema marginatum, and finally S for Sydenham's chorea. The minor criteria include arthalgia, fever, and elevated erythrocyte sedimentation rate, or ESR. Remember, ESR is elevated in cases of inflammation or infection. Okay, now that we've gone through the criteria, what manifestations did the patient present with? Awesome! Let's move on to what you'll see on histology. Histological findings are usually pathognomonic of various diseases. The histological features of rheumatic fever are Ashkoff nodules and antischouw cells. An Ashkoff nodule is a central area of necrosis surrounded by T cells. These can be found within any layer of the heart. Thus, rheumatic fever can be classified as causing pancarditis. Also, Anishkow cells are enlarged macrophages with caterpillar-like chromatin which are present in the nodules. Before we move on to rheumatic heart disease, we must discuss the changes that occur on the outside and then move inside. Rheumatic fever results in pericarditis. The pericardium is said to have a bread and butter appearance due to the fibrinous exudate present on its surface. Please note that I said fibrinous and not fibrous. Fibrinous exudate is one in which there is a lot of fibrin forming strands and sheets, thus creating a loose adhesion. This is usually an acute stage, which can later result in fibrosis. Rheumatic fever also results in endocarditis. This involves valvulitis, where there are small vegetations known as verrucae along the commissural lines. These occur after necrosis and can lead to the formation of a thrombus. Remember that after injury, there will always be healing. Therefore, the valves will become fibrotic, and this results in permanent damage and deformity. The valves normally affected are mitral valve only, which accounts for 66% of cases, mitral valve and aortic, which occurs in 25% of cases. Other valves are relatively uncommon. What I want you to do is make the linkage between the mitral valve being affected and then the aortic valve being affected. They are both on the same side of the heart. Thus, with damage to mitral, the next valve in line is aortic. Since we've mentioned fibrosis of the valves, it's time to move on to rheumatic heart disease, which is essentially the chronic stage of rheumatic fever. Rheumatic heart disease involves a fibrosis which results in malformations of the heart valves. Firstly, Ashkoff nodules are replaced by the fibrous scarring. Remember how we just discussed the injury of the valves? Yeah, they have now undergone fibrosis, which results in commissural fusion, valve cusp thickening and distortion, and fusion of the chordae tendineae and atrioventricular valve thickening. Therefore, if these consequences of fibrosis occur, what do you expect to be the result in the mitral valve? Correct! Mitral stenosis or fishmouth stenosis. Mitral stenosis is the failure of a valve to open completely and obstructing forward flow. This is the primary feature seen in rheumatic heart disease and is the only acquired cause of mitral stenosis. Now, let's look at the complications and let's think about it logically in a sequence. If there is open stenosis of both the mitral and aortic valves, that means they are stuck in a partially open position due to the fibrosis. If open stenosis occurs, as blood is being pumped, there will be regulation of blood into the left ventricles as the valve is still open. This leads to an increased preload and not enough blood is being pumped out, leading to left ventricular hypertrophy. If there is a closed stenosis in the mitral valve, the left atrium will be pumping against a closed system, which will result in increased pressure in the chamber. This then results in dilation of the left atrium. Imagine closing your mouth and trying to blow. Your cheeks will expand due to the blockage. Other complications include thrombi formation due to the damage of the endometrium and the stasis of blood in the chambers. Arrhythmias may also occur as the left atrium tries to fight against the stenotic mitral valve. Heart failure can ensue as the stenotic valve leads to pulmonary congestion, which then leads to right ventricular hypertrophy, which will eventually lead to failure of both sides. Now, with all that said, you really don't want rheumatic fever to be undiagnosed in children, which can then progress to something as serious as rheumatic heart disease. So know your diagnostic criteria, the key histological findings, and understand what really happens as you progress from acute rheumatic fever to chronic rheumatic disease. It really involves moving from a state of being damaged to a state of repair. But as you know, the repair is through fibrosis, so nothing will ever be the same. And that's a wrap.